The National Cardiovascular Data Registry is a rich source of information. What does it mean to you, though, besides being able to look at some really interesting papers? What does it mean to the practicing clinician? I am with Dr. John Rumsfeld, who is the Chair and Chief Science Officer of the NCDR, as we call it. How much fun is this? We had the NCDR meeting before this, and now you're here talking. Is NCDR fun at this moment?
NCDR is very fun at this moment. It has grown tremendously. I think it used to be a small endeavor. It was a single registry. It's now 7 national programs. It used to be something that was separated a bit from what we do as clinicians in our daily work, and it's becoming integral to what we do in our daily practice. And as it's growing and becoming more and more relevant or providing value, I think, to ACC members in their daily work, that's pretty fun.
I mean, in CardioSource World News, we're always summarizing data from NCDR because you have some fascinating papers. For the practicing cardiologist, what does the NCDR have to offer?
See, that's a great question. People do focus on saying it's a registry, so it's just about data, or what's the research. Both important, but what I think they're missing is that we're working very hard for NCDR to have direct relevance to clinical practice. Let me just give a couple of examples. One is tie to education. That is, we all know that we're under increasing pressure for maintenance of certification, our various certifications, also maintenance of licensure. And NCDR data is now being used for the first time for people to use it for their maintenance of certification credit. We had a track at the NCDR meeting, a physician administrator track for the first time, sold out 120. Using their own NCDR data from their practices or hospitals and putting into the American Board of Internal Medicine Maintenance of Certification Part 4 credit. So you can, I think in the future what you're going to see, you're going to come to this meeting and others and work with your NCDR data from your practice or hospital to get your MOC credit. The second thing is the quality reporting. We're all being measured. We have to report to this insurance company, to the federal government, to the state government, and increasingly we're getting the ability for your NCDR data to be used instead of administrative claims data for that. They're buying into the idea where you'd have control over your own data from your practice or your hospital and have that used as your quality reporting.
One of the problems I hear of occasionally is that you'll get an NCDR report, you'll look at it, and you're not sure what you're looking at. How much education is involved in understanding what you're looking at?
It's pretty straightforward, but you hit the nail on the head. Just like we wouldn't do any new procedure or go into a new clinical area without at least getting some education, some input, perhaps a little training on it. Same thing in quality. We're putting together quality training, both didactic to get MOC Part 2 credit and a training session on how to read and use your NCDR data to get Part 4 MOC credit. We piloted that at this NCDR meeting. We're also having a session here at ACC 13, and I think by next year what you're going to see is that all ACC members will be able to sign up, come here, learn how to read and interpret their NCDR reports, use them for meaningful performance improvement, and to get credit for it.
This move towards quality is not going to stop. I mean, our cover story in the March issue of CardioSource World News is on the Valley of Death. Doctors are walking through a very difficult period right now, but the emphasis, if they're waiting for it to go away, it's not going to.
So I completely agree. It is a very cloudy, if not smoggy, healthcare environment that we are living in. And I think what I'm saying is there's no single solution to that, but let me pose this question. Right now, it feels like much of this is being done to us. There are state and federal regulations for reporting on quality. There's all sorts of things on the internet judging our quality. And there's a lot of judgment based on insurance claims or administrative data. Why can't we use our own clinical data that we have some control over to have this be the way our quality is judged? And I think too few clinicians think that they have control of the NCDR data. You do. If you're in the Pinnacle ambulatory registry, it's your office data. It comes back to you. We get it out of the EHR too, so it's data capture, not collection. And with the hospitals, most cardiologists are affiliated with, integrated with, or work for hospital systems now. They should go find the performance improvement people in the hospital, go get your NCDR reports and sit down with them. It's